So it's at the costal margin.
A. Today we're going to be doing cross-table lateral hip.
Right, costal margin. And we want this parallel with the femur head. So,
Yes, ma'am.
Look at it, it actually gives you instructions for doing the sunrise too.
Does it really?
Yep,
How handy is that?
I know. I mean, you know how to do the sunrise, but it tells you the benefit of using it.
Yeah. It's too bad all of our equipment doesn't come with instructions.
how does this work?
Okay, Ms. Jen, I can't remember, but I think if you flip that thing around, it's going to be more stable. You see what I mean? Yeah, see if that works a little better. I don't know. Maybe that might actually be worse.
It is worse.
Okay.
I've never used one of those.
It's also not high enough.
Yeah, I was supposed to work.
That thing's going to work, trust me.
Let's get a chair.
Okay, well, we can definitely use a chair. We can improvise with that. But before we go to chair sitting, let's try this one more time.
Press your, like the middle of your foot like that.
Ah, gotcha.
Okay, how's that?
That's good. However,
Are you going to be able to hold that pose?
Yeah, let's move the tube this way.
All right. Let me switch over here to a little bit better angle because all I was getting from the other direction was the back of somebody's jacket. Okay, so we've got the patient's leg picked up as far as we can get it, probably about 90 degrees from the table.
Yeah.
Okay, got your image receptor. Now remember that the patient's femur, the neck of the femur is almost at a 45-degree angle. And if you look at our skeleton, you'll see what I'm talking about. So what we're going to do is, and I know this seems weird, and you're not going to like this because it's got a lot of OID. But trust me, this is going to work. The other thing we need, where's that blinking grid? Here it goes. Grid. All right, this side now.
Does that one click on or no?
No, ma'am, it does not. However, we can just slip it right in here. With this grid holder, that's going to be fine. Okay, now this thing is a linear grid, so we just have to be on the same level, but we can angle into it, it'll be fine. All right, now, Miss Jen, what do you think of your tube angle?
My tube angle needs to be parallel to the IR and to the femur head.
Correctamundo.
So I need to
Take some of the pivot off.
Because that tube's not going to go anywhere. So now, what you kind of can do is kind of set it up. You think that
kind of leave parallel if you look from here.
Okay, well, here's what you can do. Stand back here and see, because like from here, you can see exactly where your central ray is going.
Yeah.
Okay, and see where your image receptor is relative to your light field.
Yep. So it's not necessarily going to be parallel to the IR then.
It will be. I'm going to show you something. Now, I hate the word trick, because sometimes, you say, well, here's a trick, and people kind of get hung up on that. This isn't really a trick. This is just a methodology for doing things. But it's going to serve you well. Okay, now, first things first. What I'm going to do is I'm going to hit this pivot button, and I'm going to take this dude around like this. You can kind of see where I'm going with this. Okay, now, I'll swing my tube this direction. And now I'm coming on down. Okay, Jen, come here. Okay, now take a look. See? Okay, what we're going to do, and y'all aren't going to like this much either. We're going to be shooting like right through the patient's groin.
That was a crazy one.
Yeah. And I'm going to
Angle with an angle.
Yeah, you're going to feel it.
Oh, this one you just kind of did it.
Yes.
Okay, and I know you're probably wondering, wait a minute, Mr. Lee, how do you know that you're at a 45-degree angle relative to the table? because I've got these cool floor tiles. These things are, the way the tiles are in this room and in a lot of x-ray rooms you're going to find, the tiles are 45 degrees from the table. So if you're lined up with that, then you're going to be dead on. Okay, now what you got there is going to work. What about our SID? SID is theoretically supposed to be 40 inches. Can we get a 40-inch SID with this setup?
No.
Yeah, maybe not, but we can get a little closer. You can get Mr. Ben to help you. Just use that tape measure. It is. It's on there somewhere. You just have to, there you go, because it's recessed. Okay, so we're going to tape measure this thing off.
48 or
Okay,
49.
so we're at about a 49-inch SID. Now that's not a deal breaker, but can we come a little bit closer?
Yes.
Really quiet, really quiet.
Got it.
Okay, now we're up against the table, so that's about as close as we're going to get.
Right, and so that would be like 44.
Okay, so 44 inches.
That's pretty good.
Yes, that's really good.
Closer to the edge, so I couldn't have made it easier.
Yes, ma'am. That's very good. Okay, our patient has suggested moving closer to the edge of the table. Now, we can do that provided we trust this patient. You know, is this person conscious, and are they with it enough to where we
They're
can...
not going to fall off.
Yeah, exactly. Because if all of a sudden they decide they need to go to the bathroom and they roll over, then that could be a bad day.
Well, we had a patient yesterday fall out in the bathroom with the door locked. And the doctor had to take like a screw and beat the door and get it open.
Oh, gosh. Okay, well, that's not a good outcome,
Dang. Sight of that?
but that happens.
The emergent ortho and Porter's in there. But the doctor thinks the lady was kind of putting on because her daughter went in there and was kind of like embarrassed and like rolling her eyes and stuff because the lady got up and was like, I'm fine.
Uh-huh.
Oh, okay. Well, it is totally possible for somebody to, you know, like they stand up, or people that are dehydrated especially. Otherwise they're fine, but they might pass out for real. And then, you know, once they hit the deck and their body has time to, you know, kind of recover a little bit, then they get up and they're okay.
So where would you put your marker?
Okay, you see that light field up above her leg? That is a perfect place for a marker. Now, which leg is this?
Left.
Yes, it is. Oh, man. Dang it. That was almost a perfect throw.
I need some coffee.
Okay, so left marker is going to go right there in the top of the light field, so it's going to be out of the anatomy for sure.
Yep.
Okay, very good. Now, that's good positioning for cross-table lateral hip.
Okay. 10 by 12 lengthwise.
10 by 12 lengthwise, and make sure that your grid lines are going to go cephalic to caudal, superior to inferior.
All this fun stuff.
Okay, so we've got a patient here, and the patient's been in a car crash, and she's obviously bleeding, and EMS tells us that her right leg is almost certainly broken. So we've already taken an AP image of the right hip as it lay and discovered that it is in fact in two pieces.
Gonna have to move that for a second.
Left leg is totally unaffected, so we can definitely move the left leg around.
No, I just raised it to someone else see. Like, she had it like right here to her So you had it open if you want to. You see how it was right?
All right, Miss Sandra, you got any suggestions for Mr. Ben?
So she,
Does it need to pivot the tube the other way?
I agree. Because see how the crane is right in between us and our patient?
Yeah.
So really, like, you put the top of the cassette.
It's like the most pivot practice work ever.
Yeah.
So that's why I was kind of like, I bet you that's the wrong way.
You're right.
It
Come
was
back.
right this way,
Yeah,
and then
Yeah,
flip.
and as a matter of fact, with this particular tube, you'll feel it click whenever you hit the 45-degree mark.
With pivot?
Uh-huh. And, yeah, and it's also marked on there.
Top of the cassette was so like right above the press. Do you understand the relationship?
Okay.
Yeah.
Question.
Yes, sir.
Assuming this patient is unconscious and we're having difficulty getting her unaffected leg out of the way, right? So let's say she's totally unconscious and I try to put her leg here and it like keeps falling, or I can't get it out of the, you know what I mean?
Right.
Shot.
Well, we could do that,
We could use a chair, but
right? We could also use tape, for example.
okay.
That room will be good last.
Because I feel like I'm almost where I need to be.
I think the paper is like you were done.
Well, that was, yeah.
Okay.
All right. She is a very helpful patient.
All right, now then, boys and girls. Oh, you're good, you're good. Okay, remember those lines on the floor that I was telling you about? Okay, what we can do is we can use those lines on the floor to help us position our image receptor also. I told you weren't going to like this because the OID is going to be greater than what we usually are used to seeing. But that's okay. What we're going to do, I'm just going to swing this grid holder like this. I want this grid holder to be parallel to these lines here. You see what I'm talking about?
Yeah.
Okay, now that's approximately correct. Yeah, and you typically won't be, okay, there is a chance you might be doing this solo, but ordinarily you'll have help.
Okay, so
Looking at your angle, that looks good.
that is
Yep.
about the best. That's as far as I can get the tube to go.
Okay,
And I think
super.
that's about as parallel as I'm going to get the tube to
And-
the receptor. Other than maybe moving the table slightly. That might do.
There you go. Okay, you got your central ray is even with the patient's, because you can't see the patient's femur, but you know it's going to be somewhere inside their thigh. So just try to center up to their upper leg. And unfortunately, the central ray is going to be right through the patient's groin. Now, what we can do, Mr. Ben, what? Dang it. Okay, what I'm going to do is I'm going to open up inferior to superior. Okay, because I want to make sure that I don't clip anything. And I've got film. And then I'm going to cone down a little bit. I want to make sure I've got light on the image receptor and light on the table. Okay, now can you jam that image receptor any more into the patient's ribs?
If she's unconscious, I'm sure.
There you go.
Without hurting a weak patient.
Exactly. Yeah, if you start moving the image receptor and they start squealing, then that means you pushed it too far. All right, very good. We've got a right marker and it's in the light, so it's not going to be in any anatomy for sure. And your image receptor is centered as much as possible. Our CR, yeah, everything looks in good alignment. All right, I think we're ready to take that picture. Now, what kind of SID do we have?
Let's check.
Miss Sandra, help him tape it off.
48.
Okay, 48
4 feet.
inches. Now, if you're in a practical, okay, like if we're doing this for real, like if we're in the ED, I'm going to go ahead and shoot this. I'm just going to increase my technique by about 50%. That'll make up for the additional SID because I'm not at a 40 inch, I'm at a 48 inch.
Okay.
If you're in a practical, then you can say something to the effect of, okay, I've got a 48 inch SID here, I'm aware of that, but I'm concerned that if I bring the patient closer to the edge of the table, it might fall off. Now, if my patient's with it, all right, wake up, patient. All right, patient's with it and not too terribly injured. Ma'am, can you scoot over towards the edge of the table for me? Towards me. There you go. All right, super. All right, now I can get my 40 inch SID. But if my patient's unconscious for real, then I'm not going to do this because, you know, if I'm not careful, they could roll off onto the floor. And that would be a poor outcome for the patient. All right, very good. And here's our setup for cross table lateral hip. All right, excellent effort. And now for our next trick, proximal and distal AP femur.
So why she's here? Why don't you want to do the AP?
All right, Miss Sandra, open that thing up to 17 inches long. There you go. 17.1 is okay. 16.9, that works. Close enough. We just want to get as much femur on there as we can. Okay. All right, ma'am, I'm just going to be feeling for some of your bones here. Nothing to get excited about. Okay, right there's ACES. And all right. Now I'm going to, because what's going to wind up happening is you're going to get her to turn her toes in, and when you do, then she's going to be pretty much lined up, dead center. There you go.
That's so low.
Okay, now we're going to put a marker on there. Which marker are we going to put on there? Okay, now move that marker closer, because remember, we collimated in side to side. There you go. You can do that.
I like to be able to see it.
Put it in the light field. That way we're sure it's on there.
Yeah.
Okay, very good. Now, can we shield for this examination? Yes, we can. We just have to do so carefully.
Now, should I shoot it over here at the light or up?
I would shield like right above the light. There you go. We're going to shield the patient's tummy as much as we can. Okay, very good. Okay, now for a patient that's legs aren't like super long, it is possible, yes, you could swap out for a 10 by 12. Because, okay, look, like right here goes her patella, and so you just need to be like another finger down beyond that patella. Yep, that looks good. And is the shaft of her femur is relatively centered to the light field? No. So grab a hold of her toes, and there you go. Much improved. Okay, very good. So that's going to give you your distal AP femur. Yep.
Okay, can you roll to your left side?
It's a little bit chilly in the radiography lab today. Chilling out.
Think about it. All right. But
There you go, just float the table around. And that way you can put the patient more or less where you want them.
Well, I mean, they say like depending on looking at like what, you know what I mean?
Now, when you're doing this for the practical, if you're like moving the tube back and forth and moving the image receptor back and forth, you're going to kill a lot of time.
yeah.
You know, go ahead and get your image receptor and your tube lined up straight, and then just float the patient around.
Because every time somebody will check, they come and take it all. I mean, however you feel saying it,
Yeah.
this is here, right?
So
What you
now-
doing?
So,
She's trying to palpate herself.
yeah,
Okay, if you can't find your own ACEs, then that's bad.
I
That
know.
is bad.
Here it goes.
Okay, got it. All right, now then, can we fit this whole patient's leg on one 14 by 17?
We sure can try.
I think we might,
Just increase this.
actually.
The thing is, like, I think there's that set of these.
Mhm. And open up file manager. Oh, yeah. You might be able to do the 90 and fit distal as well. Yep.
I think you can. I think on this patient's femur will fit diagonally on a 14 by
She's in
17.
the light.
Now, we're going to take our image, and what if we take this image and we realize that, oh, geez, we clipped off the acetabulum, but we got everything else?
Acetabulum?
Then we can just put in a 10 by 12 and then just do a shot of just the top of the femur,
Yeah, because I don't know. I
like
can't really
a
tell
hip X-ray.
if
Yeah.
I'm up there.
Yeah.
I think you're probably going to be on there, honestly.
Oh, yeah. Lateral proximal femur. Proximal and distal.
Yeah, for that
Because we
one we got
fit- we fit her on
proximal and
there.
distal.
Sweet.
Has everybody done it now?
Everyone's done that. So now we can